Can somebody summarize what we have studied yesterday? Just a few sentences about yesterday topic. Hasita, would you like to say something?
Yes, madam. We discussed about the prevalence of anemia and what are the causes and outcomes of anemia. And we discussed about erythropoiesis, how it is done, and places where they are done, and red cell. We discussed about red cell hemoglobin, and we discussed about clinical features of anemia and lab investigations. We discussed about principles of treatment and prevention of anemia.
And we have done some activities, isn't it, just to recap the knowledge.
Yes,
and one thing you have missed it, the definition of anemia.
Yes.
And also the different levels of hemoglobin values for different age group and sex, because that we have to have some idea about that. Otherwise, we won't be able to diagnose anemia. So you all have to have some sort of an idea about how these upper limit, the level ranges varies with each different age group and the sex. So very good, Hasita, you have summarized. So that's very nice. So today we going to do a lecture on macrocytic anemia. So I think yesterday I have introduced this. Yesterday, can you all mute your microphones, please? So today, so I think yesterday I just introduced this word macrocytic anemia, and also I have shown some picture how the macrocytes looks in the blood picture when we see under the microscope. So I have shown some microscopic photographs yesterday. So probably you all must be having some sort of an idea how this macrocyte looks like. So again, the learning objectives of this lecture is you should be able to define macrocytosis, and you should be able to list down the causes of macrocytosis and physiological as well as the pathological causes. And so one of the causes for the macrocytosis is vitamin B12 and folate deficiency. So you should be able to list the causes for vitamin B12 and folate deficiency. And also you should know about some of the clinical manifestations, how these patient presents when they have vitamin B12 and folate deficiency. And more than that, if somebody presents with this clinical manifestation, and how you will investigate that particular person in order to arrive at the diagnosis of vitamin B12 and folate deficiency, and also interrupt the results of above investigations, and then you have to how to treat these vitamin B12 and folate deficiency, and how you can assess the response for the treatment. So these are our learning objectives, and hopefully you all must be having in your module handbook these learning objectives. So what is macrocytes? So these are the large red cells where you can see this is the microscopic photography of this blood film, where you can appreciate it. These are the normal red cell. And when you compare this normal with that macrocytic blood picture, you can appreciate that the size of the cell is bit different and bigger than the normal red cell. And also the other one thing I have mentioned yesterday also, you have to look at the central palo area. So where the normal red cells will have the central palo, whereas in the macrocytic cells, they don't have this central palo areas. So there is another blood picture also where you can appreciate there is a mixture of normal cells as well as the macrocytic cells. And how these macrocytes occurs because of this diameter of the cell will be increased, and also when you do a full blood count on the patient who has this macrocytes, if most of those cells are macrocytes, then you will have high MCV in your full blood count report. So this is another diaphragmatic representation of chromasia from this y-axis, and x-axis shows the size of the red cells. So, look at these chromasia of these cells. So these hypochromic, so you can see that you can appreciate the difference in the intracellular color. So here this looks more darker than this cell. So these hypochromatic cells, this is hyperchromic cell. So this is how the normal cells looks like. So when you take the size of the cells, you can appreciate the difference of the cells. This is bigger than the normal cells. This is smaller than the normal red cells. So then you call as a macrocyte, and this is microcyte. So yesterday I mentioned, so hopefully you all will be able to appreciate this difference in this diagram. So the morphological difference in macrocytes. So we know what is macrocytes now, and you can appreciate the difference in the morphological appearance of those macrocytes. Here, look at this blood film. You can see obviously this is a bigger cell, but look at the shape of the cell. Whereas when you compare this cell, so we know this is also increased diameter and bigger than the normal red cell, but the shape of the cell is a bit different from the shape of this cell. So then we call this is round macrocytes, and this is an oval macrocyte. And why we should know this difference? Because you can further narrow down your differential diagnosis if you appreciate this shape of these macrocytes. For an example, if it's an oval macrocytes, usually it happens in the megaloblastic anemia due to vitamin B12 and folate deficiency. So that's why you should, so just identifying the macrocytes is not enough, but you should be able to describe the macrocyte, whether this is oval or whether it's a round macrocyte. And if you see some round macrocytes in the blood film, and less likely due to the megaloblastic anemia, so what are the causes for round macrocytes? So you can see some of these examples of round macrocytes are liver disease, and myxedema is a hypothyroidism. So in these conditions, your red cell is going to get bigger, and the shape of those red cells round shape. And as you all know, polychromatics, we tend to call those cells as a reticulocytes. So we call polychromatic when we do the blood picture on the Leishman stain, whereas we call as a reticulocyte when we do the supravital stain. So that's the same cell we are referring, depend on which stain we use to stain the blood film. So if it's a Leishman stain, which the cells looks like a pink or a purple color, so then then those cells are called as polychromatic. So where you can see these polychromasia. So you should know about what are the conditions can give rise to increased reticulocyte count or polychromatic cells. So obviously we know hemolysis or hemorrhage can cause increased reticulocyte count, because in hemorrhage there will be a blood loss and your bone marrow starts to produce more and more red cells, as a compensatory mechanism for your bleeding. And when there is so many cells having increased the production of red cells, and your increase your reticulocytes also happen in your blood film. Again, in hemolysis, also there will be a destruction of your red cell. So that's happening in the peripherally. So if there's a destruction, your body bone marrow try to produce more and more red cell in order to compensate the anemia. So you will have a stress marrow, and it will put up more cells in your blood in the peripheral blood. So that's so when there is an increased polychromatic cells or the reticulocytes in the peripheral blood, even you can again you appreciate the cells which looks like more larger than the normal red cells. And also, so mainly when you try to look for differential diagnosis for your macrocytic blood picture, not only description of these round, oval, or polychromatic cells, always you have to look for other morphologic features in the other cell lines. That means if anything goes wrong in the neutrophil, or if anything happens to the platelet, always you have to look that also in order to arrive at the diagnosis. I will be I will be show some blood pictures later on when I'm doing further. Then I can show what are the other changes can occur in the other cell lines. So these are some more blood pictures. In this microscopic photography, I'm trying to show these are the polychromatic cells, and this is not the mature red cell. This is a reticulocyte. You can appreciate the color difference of the normal red cell and the polychromatic cells. So it looks more darker purple color than the normal red cells when you stain with a Leishman stain. So sometimes we tend to misunderstand these cells also saying this is a macrocytic red cell. It's not so, because this is looks like it's a reticulocyte. Because of these high diameter cells in the peripheral blood, your full blood count report your machine will count these cells as a larger cells, and your cumulative MCV will be high. So that's why we take polychromatic cells also one of the differential for the macrocytes. So this is a supravital stain. You can appreciate the color difference in this blood picture and also this blood picture, because this is stained by the Leishman stain, which we usually use to stain the blood films, whereas this is here the supravital stain has been used in order to stain the reticulocyte cells. So even these you can appreciate it, because your mature red cell doesn't have any nuclear components, whereas in the reticulocytes you can see some Bregman RNA. So that's why it stains like little bit purple color. So whereas you can't see in the normal Leishman stain, always we ask for supravital stain to count the reticulocytes count. So what are the causes for macrocytosis? So if somebody sees some macrocytes under the microscope, then always is clicked, it could be a vitamin B12 and folate deficiency. But always you have to think, or you have to remind that there are other causes for macrocytosis as well. So always you have to think about whether is there any cause other than the megaloblastic anemia in this patient. So history is very important in order to gather some information whether this patient might have some other causes for his macrocytosis. As you all know, in the physiological conditions where the neonate and the pregnancy, they can have macrocytes in their peripheral blood. That is normal, because this is the physiological changes that happen in these two group of patients. So what are the pathological conditions which can give rise to macrocytes or reticulocytosis As I have mentioned earlier, in the condition of hemorrhage or a hemolysis, your marrow try to produce more and more red cells. So they will put all the immature cells into the peripheral blood. Then that looks like bigger than the normal red cell and give rise to the condition reticulocytosis. That's also mimic the picture of the macrocytosis. And of course, we know is the megaloblastic anemia is one of the cause for macrocytosis. And what else other condition except this megaloblastic anemia is excess alcohol intake, liver disease, mixed edema. Because why you should know all these causes? Because in order to ask for investigations, you should know these are some of the differential can come into this patient's condition. So I have to request relevant investigations. For an example, liver disease, you will ask for the liver function test and thyroid function test for mixed edema to rule out. So that's because you should know what are the causes for macrocytosis. And not only this condition, but some drugs also can cause macrocytosis. For an example, phenytoin or cytotoxic drugs. And there are other pathological conditions, myelodysplastic syndrome, myeloma, and some of these inherited or congenital causes for anemia. CDA, we call that as a congenital dyserythropoietic anemia type 1 and Diamond-Blackfan syndrome. These are the congenital causes for anemia. So nice to know these names like CDA1 and Diamond-Blackfan syndrome if somebody asks the causes for macrocytosis. But we usually take the last two causes if we are investigating a little boy or a girl. If you see macrocytosis, you always keep that in your mind. These two causes also can cause macrocytosis. And cold agglutination is because of the facetious we call, because I'll show you in the next slide why we call cold agglutination and cause also one of the cause for the macrocytosis. Here, this is how when somebody is having a cold agglutinin disease, this is how you see the microscopic photograph picture. This shows all these red cells are clumped together. Here, look at here, because it's not separate from each other. These cells are clumped. So there will be 4 or 5 cells in this clump. Look at here, maybe this is here 20 to 25 red cells are clumped together. But unfortunately, our full blood count machine will detect this cell as a one cell because it can't separate these 4 cells into separately. They calculate this is a one larger red cell. So that's because when you see the blood report, you can see high MCV in this condition because all these cells are counted as a one cell. So that's why we call here in this particular condition, there is no macrocytosis, but falsely it gives a picture of high MCV. So if somebody presents with a macrocytosis, how would you investigate that patient? Again and again, I'm mentioning history is very important. Always history gives, you can gather more information. So these are some of the examples. Alcohol intake, you should ask, and dietary history is very important in order to arrive at the diagnosis of vitamin B12 and folate deficiency. That's why dietary is very important. So any patient with presence with an anemia, always you should not forget to ask dietary history. So that's the one big component in your history taking. And same equal importance is examination in order to arrive at the diagnosis. For an example, if there is a liver disease, patient will have all the features or some of the features suggestive for liver disease. And hypothyroid features, always you have to look into those features when you're doing examination. So then history and examination, then you will ask for some of the investigations, lab investigation, in order to arrive at the diagnosis. So lab investigation, so everybody knows full blood count is the first investigation you will ask for it. Equally, you will ask for blood picture and also reticular sign. These three goes together. So any patient with anemia, all three answers should come. For all three investigation you should request. Otherwise, you won't be able, you can't get a proper picture or proper idea about why this patient is having anemia. So as I have mentioned earlier, not only look the morphological appearance of red cell, equally you have to look into other any morphology features, look in the other cell lines. So blood picture morphology of macrocytes and changes in other cell lines. So can you all appreciate it here? So can someone tell me how the normal neutrophil looks like? Hello, can someone tell me how the normal neutrophil looks like?
It's a granulated cell, and there's nucleus with 2 to 5 lobes.
Yeah, so this looks like normal, isn't it? This neutrophil. Because you have to always count the lobes in the neutrophil. So can someone tell me how many lobes in this neutrophil?
4.
4, very good. And how many lobes here?
About 8.
8, very good. So you can appreciate this difference because normal neutrophil, you try to get between 3 to 5 lobes. That's the normal. So if it is more than 5 lobes in the neutrophil nucleus, then you call that as a hypersegmented neutrophil. So this is one of the other morphological features supportive for your diagnosis of megaloblastic anemia. So that's why I told you not only look the red cell, equally you have to give an importance to look the other morphological features suggestive of your diagnosis. And also the other thing is a pancytopenia, which you can appreciate in your full blood count, and equally you can confirm that pancytopenia by looking at the blood picture as well. And obviously the reticulocyte count. And these are some of the other investigation you will ask in order to exclude the other condition or arrive at the diagnosis. So liver function in order to exclude the liver cell disease, thyroid function to hypothyroidism, hemolytic screening. Can somebody tell me what are the hemolytic screening tests? You will ask for it. Any guesses? I know that there will be a lecture maybe next week. So can any ideas about hemolytic screening?
Prothrombin time and APTT.
No, I'm asking hemolytic screening, not the hemostasis.
Porphyria levels.
Sorry?
Serum porphyria levels.
Serum?
Porphyria.
No, hemolytic screening, you won't ask that.
Serum bilirubin levels.
Very good. One is the bilirubin level. So what else in the bilirubin you will ask for it? So just the total bilirubin will give some idea, but you have to ask for
Unconjugated bilirubin level.
So always you have to ask for the split bilirubin level. Split means unconjugated and the conjugated. So here they call as a direct and indirect bilirubin. So then in the hemolytic, you will get indirect hyperbilirubinemia. So that's supporting your diagnosis of hemolysis. What else you will ask? Any guesses?
LDH level.
Very good. What else? Probably you all have studied in the biochemistry. If something hemolysis, your unconjugated bilirubin goes up, what will happen? You can ask for some urine tests as well, isn't it? Urine for bile, urine for urobilinogen, those things you also can ask. And obviously, if under the hemolytic screen, you have to mention the full blood count, blood picture, retic count as well. It comes under that as well. And usually we don't really wait until see the blood picture. If you suspect the hemolysis, you ask for one of the other tests as well. Any guesses? Or did you all hear about Coombs test or direct antiglobulin test? No, not yet. So that's also another test which you can do in order to differentiate the immune-mediated hemolytic and the non-immune-mediated hemolytic. That's fine. I think there are lectures on hemolytic anemia as well. You will get to know those investigations. Okay, so then you have to ask for focal bleeding, or because in order to exclude the hemorrhage, or just to exclude the polychromatic cells in the blood film. And second line investigation, there will be a flow chart further down in my lecture. Then you will get to know what are the second line investigation you will think about in macrocytic patients. And before I jump into other investigation, I just wanted you all to know a little bit about this red cell indices. So red cell indices, if somebody is talking about red cell indices, then you should know they are talking about MCV, mean cell volume, MCH, mean cell hemoglobin, mean cell hemoglobin concentration is MCHC. So there is a definition for that, which you all can read yourself, and I don't need to read those things. And you should have some little idea about units. MCVs, we usually say it in femtoliters, and mean cell hemoglobin we say it in picograms, and MCH we say grams per deciliter. And this is some of the formula. These formulas help to calculate manually, because if you know the hematocrit and the RBC, you can calculate the MCV. So because these are measured by the machine, because some of these automated hematology analyzers, which we use the machine for full blood count, it doesn't measure directly the MCV. Then you have to get these values and you have to manually calculate it. So I think it's better to know about this formula for MCV, MCH, and MCHC, because these are very helpful red cell indices in order to think about the differential diagnosis. So you should be able to calculate these two if somebody is not given the MCV in your full blood count results. So because MCVs plays a very important role in order to classify the anemias. So this is how your report comes. Yesterday also I mentioned this red cell histogram, and I explained yesterday how this histogram is formed and how we calculate the MCV in the RBC histogram. So this is one of the picture of how the automated hematology analyzers will be, and the good thing, some of the advanced automated analyzers, they can measure MCV directly rather than using those formulas, manual formulas. And so this is rough. This is just to know about this, how the measurement of MCV in the automated full blood count analyzer, because there is two principles, though the mechanism would be same, but they use one method is a impedance method and the other is a laser optical method. So there's two methods which you can use this to measure those full blood count tests. So how they measure the MCVs, because why we are talking more about the MCV, that's one of the important or the key red cell indices helps to differentiate the types of anemia. So that's why we talk about MCV. It's better to, I think it's you should know about the how the MCV is measured and what is the formula for manual formula for to calculate it. So this is here they are using the impedance technique. They use a electronic field between those two electrodes. And here the laser optical method, they use the laser beam. And what will happen is, the good thing is the cells travel one after the other. So it just goes in a line. So it doesn't go rush like 1, 2 on the same time. So every time when they pass these fields, they just one cell will be go through that field. So the good thing is like when they pass one cell, they can detect the size of the cell. So look at here. The depends on the size of the cells. Your amplitude might vary. Here is a bigger cell. Here is a normal cell. So likewise in the laser beam, there will be a diversion of the laser beam here. Depends on the size of the cell. Look at here, the larger cell. Your diversion of the laser beam is bit farther than the normal cell here, the diversion. So these will be picked up in the detector. It will be detected in the detector, and they'll say how much the MCV is. So that's why they calculate it here, the laser beam technique, and the impedance technique. They use the electronic field here. And so that's how they calculate the MCV. Now we will come back to our investigation of macrocytosis. So as we know, when the patient have macrocytes, we come into conclusion by the macrocytes in the blood film or the high MCV in the full blood count. So obviously the history, I won't go through again and again the same thing. Then you will ask for full blood count, and this is some full blood count. Then you ask for the reticulocyte count. Depend on the reticulocyte count, you will decide what sort of investigation you have to ask for it. So as I have mentioned earlier, high reticulocyte count, we know that happens when there is a hemolysis or hemorrhage. So you have to investigate in that line, and you try to diagnose this condition by ordering the relevant investigations. Whereas if the reticulocyte count is normal or low, then we know we have to ask if something goes wrong in the production. So there will be the causes for production defect. The LFT, you have to ask for hypothyroid, thyroid function, and sometimes you can ask for ultrasound scan abdomen, and mainly you'll ask for the serum vitamin B12 and folate level. Because this, by doing these things, you can further, if these are abnormal, then you know if it's folate low, folate deficiency, vitamin B12 low or folate high or normal, then that is vitamin B12 deficiency. If once we got those results as normal, then we bit tricky. We don't know what's happening around the patient, because some of the vitamin B12 deficiency can be there with the normal serum vitamin B12 and folate. So at this point, we have some more third-line investigations to do in order to look for underlying vitamin B12 deficiency, or we can ask for the bone marrow biopsy. If you suspect some other cause might causing these macrocytes, then you can ask for the bone marrow biopsy. If it is a normoblastic, then there will be some other causes, or if there's a dyserythropoiesis, can be a MDS. But still, with the serum vitamin B12 folate normal, still you can have vitamin B12 deficiency. So if there's a megaloblast, then you can think about whether it could be a megaloblastic anemia. So one thing you have to remember is, even though we call megaloblastic anemia, the megaloblast are seen only in the bone marrow, not in the peripheral blood. So peripheral blood we call as a macrocyte, whereas in the bone marrow we call as a megaloblast. So we go for the megaloblastic anemia. I think under the macrocytosis topic, you should know a bit more detail in megaloblastic anemia, because if somebody is formulating a question, they will focus on the megaloblastic anemia under the topic of macrocytes. So what is megaloblastic anemia? So megaloblastic anemia, the group of disorder, we can see the distinctive morphological appearance of developing erythroid cells in the bone marrow. So that's I have told you all before. The megaloblast is the word used when we see the cells in the typical morphology appearance when we see in the bone marrow. So usually, as we know, if somebody is telling what megaloblastic anemia, in your mind, the first thing comes is vitamin B12 and folate deficiency. But you should remember there are other causes also can cause similar kind of a morphological appearance without the vitamin B12 and folate deficiency. So what are those causes? There can be an inherited or acquired abnormality affecting the metabolism of these vitamins, or there can be a direct defects by the DNA synthesis by some of the drugs. So that's not related to the vitamin B12 or folate. We can use another word, is a cobalamin for vitamin B12 as well. So always you have to think about, because everybody thinks, even me when I was an undergraduate student, I also thought if somebody is talking about macrocytes, it's equal to the megaloblastic and equal to the vitamin B12 and folate deficiency. That is not so, because there are other causes for macrocytes as well. There are other causes for the megaloblastic anemia also. So always those are not equal. So you have to think about the other causes as well. So if there's a dietary vitamin B12 folate, you have to know how these have been absorbed. So I have just put only a few words about it, but better to know how this mechanism occurs, the absorption mechanism occurs. So as you all know, vitamin B12 is absorbed in ileum, but this vitamin B12 should go through so many metabolism before it enters the ileum to get absorbed. You have to know a bit about this intrinsic factor and what happened, intrinsic factor deficiency and stuff like that. And also the folate gets absorbed in upper small intestine. So once this vitamin B12 is absorbed, and when it enters into the intracellularly, because these two vitamins are important for DNA synthesis. So that's how we said like intracellular mechanism, because vitamin B12 acts as a cofactor here for formulation of methyl tetrahydrofolate to tetrahydrofolate here. To conversion of this, you need vitamin 12 act as a cofactor. This methyl is group used here to change this reaction. So because this tetrahydrofolate have to be formed in this form in order to synthesis of the DNA. So if something goes wrong in this step, then there won't be a production of tetrahydrofolate, then there will be a problem in your DNA synthesis. So that's going to happen when there is folate as well as a vitamin B12, because these folate and vitamin 12 both goes together, because it's for the function of DNA synthesis, both folate as well as the vitamin B12 are needed. So what are the causes for vitamin B12 deficiency? Everybody knows vegans. Can somebody tell me what is the difference between vegans and the vegetarian?
Vegans don't eat any animal products, including eggs, milk, or any other things, but we vegetarians take others.
Yeah, you are there, some sort of, you know that. So it's like a vegan, they don't eat the dairy products. They don't eat any animal products, including the dairy products. So dairy products are yogurt or curd or any sort of a milk products, because that milks also come from an animal. So they don't eat vegans, but while the vegetarian, they don't eat meat, fish, and that sort of animal products, but still they consume this milk products. So that's the difference between the vegan and the vegetarian. So in your case, history taking, just asking whether you're vegetarian is not enough. You have to ask whether you are a vegan or a vegetarian. So that's why I highlighted that point. What's the difference between the vegan and the vegetarian? And not only the common is the nutritional anemia, but still other causes for vitamin B12 deficiency are malabsorption. We tend to see patients with these causes vitamin B12 deficiency. So one of the gastric causes are pernicious anemia. So you should know a bit about the pernicious anemia. And also congenital intrinsic factor deficiency, gastrectomy, because in intrinsic factor produced in the gastric area. So you should know what's happening in the gastrectomy. And not only the gastric causes, but there are some intestinal causes also can lead to vitamin B12 deficiency. So mainly you should know, because if something goes wrong in your ileum part of your intestine, obviously your absorption will be disrupted. So because it's the ileum, it's a portion where the vitamin B12 is get absorbed. So there are some of the causes can causing problem the ileal part of your intestine. And what are the causes for folate deficiency? Again, the nutritional, we tend to see the older people are suffering from folate deficiency. And malabsorption, again, the same causes, and excess utilization. So these are some of the physiological conditions where you have to support or supplement the patient with folate. So as you all know, pregnancy, we tend to give folate even pre-conception period, and we ask them to continue until they go for the delivery, because the folate is utilized more, so you have to replace that folate. And pathological conditions are hemolysis, because there is a destruction of your red cells. So in order to compensate that, your bone marrow is trying to produce more cells. So those cells will be utilized, your stored folate, then you have to replace it, because usually the storage is there for only 3 to 4 months. And malignancy is also the same reason, and also some of the inflammatory conditions where the folate will be used. And excess urinary loss, some of these conditions where will be the patients will be losing folate through urine, and obviously you know some of the drugs also can cause the folate deficiency. And confirming the diagnosis. So history taking, examination, and then you will ask for some of the laboratory investigation. So once you have excluded the other causes, then you want to confirm this, whether it's a vitamin B12 or folate, you will ask for serum vitamin B12, serum folate, and red cell folate. So you should know, definitely you have to know, you have to know, because sometimes we tell in the lectures, this is a nice to know, you should know, you have to know. So there's a difference. I think you have to know these things, because if somebody is giving this level, you should be able to interpret that results in order to arrive at the diagnosis. So in vitamin B12 deficiency, what will happen is vitamin B12 is low, but your folate will be normal or raised, and your red cell folate is normal or low, because here for the mechanism you need the vitamin B12. In case if you don't use the vitamin, if there is a vitamin B12 deficiency, the folate reaction won't happen, then folate start to accumulate, then you will have the raised folate level. Whereas in the folate deficiency, obviously we know nothing wrong with your vitamin B12. So when you do the serum vitamin B12, your level will be normal, but the other two will be low. And as always I mention, anemia is not a diagnosis. Always you have to look for underlying cause. What is the underlying cause for this person to get anemia? So investigate to determine the cause of the deficiency. So if you remember the cause, what can lead to B12 deficiency or folate deficiency, then you can ask for relevant investigation. So these two investigations, I have just put the examples to show these antibodies tests have been done in order to diagnose or look into whether that particular person is having pernicious anemia. So these are some of the third line investigation. As I have mentioned earlier, though you have done serum folate level, serum vitamin 12 level, sometimes though patient having a deficiency, your levels can be normal. So that's why these vitamin B12 and the folate test, it's not having a high sensitivity or specificity. So there is a chance can be a false positive and false, these two can come a false positive or false negative. So that's why if it is low, then you know that's the deficiency, but sometimes they can have normal even though the patient having a deficient in your body, the vitamin B12. So then if your macrocytes are there, the patient is having a typical picture, despite of that your tests doesn't give any conclusion, then you can ask for the other two tests. So why we do these tests is because in our body, the vitamin B12 usually vitamin B12 acts as a cofactor for two enzymatic reaction. So one is the methylmalonyl coenzyme A mutase reaction, and the other one is the methionine synthase. So if there is a vitamin B12 deficiency, that reaction won't happen, then your substrate start to accumulate in your body. So that's because we do serum methylmalonic acid and total homocysteine levels. So if there's a real deficient in your body vitamin B12, then these two substrate will be accumulated in your body, which helps. So if all the above tests doesn't give any conclusion, then we can ask for these tests. And also the third one is the bone marrow biopsy. You have to keep in your mind, we don't really do bone marrow biopsy as a routine test in order to diagnose the megaloblastic anemia, because the other tests are far more than enough in order to diagnose it. But some patients, for an example, if you suspect the vitamin B12 deficiency, then you can give the trial of vitamin B12 and folate treatment, and you can see whether they are responding or not. If they don't respond, then we are not sure about whether the patient is actually having B12 folate deficiency or something else. In that case, you can do the bone marrow biopsy in order to look for what is happening in your bone marrow causing your macrocytes. But keep in mind, again, I'm repeating, we don't really use bone marrow biopsy as a routine test in order to diagnose B12 and folate deficiency. So if your question comes about the megaloblastic anemia and how would you investigate, don't jump and write the bone marrow biopsy as the first test. So this is how the bone marrow biopsy looks like. So in your bone marrow, you should know, we take two specimens. One is the bone marrow aspiration. The other one is a trephine biopsy. So these microscopy photographs are bone marrow aspiration. Here, this is a bit of a high magnifying power. Under the microscope, you appreciate this is how the megaloblast looks like. So why we call this as a megaloblast, whereas the normoblast is a bit different from that. Why? Because bit of a larger cell, and also you appreciate the difference between the nuclear maturation and the cytoplasmic maturation. So we usually call that the asynchrony between the nucleus and the cytoplasmic maturation, because the cytoplasm matures quickly here, and whereas the nucleus, there is a delayed maturation because of the vitamin B12 affecting the DNA synthesis, and it causes a delay in the maturation of the nucleus. That's because there is a difference between the maturation of the cytoplasm and the nucleus, where you can see some more cells looks like megaloblast. So the equally, not only it affects the erythropoiesis, it affects the other cell lines as well. So this is another typical morphology feature we look into when we see the bone marrow aspiration for megaloblastic anemia. This is we call the giant metamyelocytes. So as you all know, metamyelocytes is a bit smaller than this. That's how the normal metamyelocyte looks like. Here, this looks a bit giant. So that's why we call it as a giant metamyelocyte. So these are the morphological features, and equally it affects the platelet production. So we call that as a megakaryopoiesis. So megakaryocytes are also a bit hyperpolydiploid. So clinical effects of vitamin B12 and folate. So when there is a deficiency, not only it affects the erythropoiesis, but also it can affect all rapidly growing tissues. So that means DNA synthesizing tissues all can be get affected. So the first thing we see is the bone marrow changes, but also next most affected tissues are epithelial cells. As you all know, epithelial cells are rapidly growing cells. So where these are the organs where we can see the epithelial cells. So these epithelial cells also shows the macrocytosis, and there will be a dying cells because of increased number of multinucleate. So they can have symptoms from the other organs as well. So if you say the summary of the clinical effects, if the patient is asymptomatic, we tend to detect high MCV on the routine full blood count. But if the patient has the symptoms, obviously they can have anemic symptoms. So yesterday we studied about the clinical symptoms and the signs of anemia. You can write under this. And yesterday I told you pancytopenia. So I showed one picture. It affects the other syntheses as well. So there will be a reduction in the other counts in the full blood count as well. So that's why we call this as a pancytopenia. But it not occurs always, but can occur as well as a megaloblastic anemia can present as pancytopenia as well. Mild jaundice, because there will be a ineffective erythropoiesis, so they can have mild tinge jaundice. Abnormal cell turnover at the epithelial cells can give us, so this looks like the tongue, looks like glossitis. So when you see somebody presents a megaloblastic anemia present to you, you have to examine the tongue, and this is an angulostomatitis. You have to look all these features. You have to look it. Patient won't tell you that I'm having glossitis, I'm having angulostomatitis, but it's your responsibility as a medical doctors, it's our responsibility to look into the feature whether this particular person is having glossitis and angulostomatitis. And this is not the specific features to vitamin B12, but this more suggestive for nutritional anemias. And sterility, because it will affect your fertility as well. And decreased osteoblastic activity, you can have hyperpigmentation. And the dangerous thing with the vitamin B12 is not with the folate, only it happens with the vitamin B12. It's a neurological manifestation. As you all know, it can affect your spinal cord. We call it the subacute degeneration of the spinal cord. And so that gives us your progressive symmetrical sensory neuropathies, not only affecting the spinal cord, it can affect your brain and psychiatric symptoms and your other nerves in your eye nerves as well. It can lead to optic atrophy as well. So the dangers of this vitamin B12, once you treat, all the manifestation, majority of these manifestations are reversed. Whereas your spinal cord, once it happens, it won't be reversed with your treatment. So that's dangerous. So you have to pick these people quick early, and you have to do a prompt diagnosis and treat the patients. So little about the pernicious anemia. So you more prevalence in females rather than the male, and peak age roughly about 60 years. And these are the common prevalence in Northern European people and blood group A. And the other thing is it can associated with other autoimmune disorders. So if somebody is present with vitiligo adescens, you have to always look for whether there is a vitamin B12 deficiency and due to pernicious anemia. So as I mentioned earlier also, for pernicious anemia, we tend to do the antibodies level. So one thing is a parietal cell antibody, and the other things is intrinsic factor antibodies. Though it becomes 95% patients, it become positive, but it's not specific. So sensitive, it is you can detect, but specificity is important that we look into. If somebody's intrinsic factor is positive, though it's only detected in 50%, because in the other patient it can be a false negative. So, but it's very specific. So if detected, then intrinsic factor, then I would be thinking more towards the pernicious, and whereas the parietal, I won't conclude that as a pernicious anemia because that's not a specific test. But we tend to do both tests if we suspect there could be a pernicious anemia on this patient. Why we should look for underlying cause? One thing is you can treat the underlying cause, and the second thing is if that particular person has the defect which cannot be correctable, then you have to give vitamin B12 and folate for the lifelong treatment. You can't just give the 6 doses of vitamin B12 and you can't just leave it. So that's because you have to always look for underlying cause, and you have to decide the treatment. So the treatment, correct underlying cause, and for the vitamin B12 and folate, you can replace it. So normally we have a folic acid, which we give it 5 milligram daily. And for vitamin B12, we have a hydroxycobalamin, which is 1000 microgram IM. You keep every other day for 6 days. Or there is a oral preparation as well, which is a bit higher dose because depends on the absorption. We're trying to give a higher dose. And if we can try for the patient doesn't have any malabsorptive problem. So the either way you can treat the patient. So for an example, nutritional deficiency, you can treat first and you can advise the patient to take more foods which contains vitamin B12. So for those patients, you don't need to give lifelong maintenance dose of vitamin B12. Whereas if somebody is having a malabsorption problem or something is a congenital problem which we can't correct it, so that particular person needs a lifelong maintenance of vitamin B12. So always, this is an important point that you have to keep in mind. Always you have to start the treatment both together, not the only one, because if suppose the patient having a vitamin B12 and you have missed, and if you treat with the folic acid, this patient's neurologic condition can be worsened. So if you having a doubt, always better to treat together. So that means you give vitamin B12 and folate together. There is nothing harm if you give vitamin B12 or folate, because that if you are excess in your body, that will be excreted in the urine. So the other things always you have to remember, for any deficiencies, if you treat, always you have to assess the response to treatment. Otherwise, we don't know whether the patient is responding or not. So there are some changes. You have a timeline here to see the response. So peripheral neuropathy can be improved, but not the spinal cord is irreversible, which I had mentioned earlier also. Patient feels better within 24 to 48 hours, and always we tend to, in clinic, when we treat the patient, if we give the drug, we usually get down the patient in a month's time with the repeat hemoglobin to see whether the patient hemoglobin has gone up or not. If we expect the rise is every 2 weeks, there should be a hemoglobin rise roughly about 2 to 3. But it's not a hard and fast rule, but roughly we expect actually at least a bit of improvement in that patient. Then we can continue the treatment. Or if there is no improvement, then you have to think about some other causes for megaloblastic anemia. And retic response is a good thing. You can assess within a week's time, and WBC and the platelet count become normalized in 7 to 10 days, and marrow normoblastic in 48 hours. But we don't usually, even we don't do the marrow to diagnose it. So why we have to do the marrow in a response to assess the response? So this is, we don't really use this method, but of course we do these things. We get down the patient in a month's time and we repeat all the things and we see whether there is any response to the treatment. So in summary, so I have covered what is macrocytes and causes for macrocytes, and what are the, mainly we focus on the how to investigate macrocytes, and the one of the key causes is vitamin B12 and folate, and we studied about those, how to investigate and what are the causes for those deficiency and how to treat and how to assess the response. In meantime, I have just covered a bit about the MCV calculation and why importance of knowing the MCV. Any clarification or anything before we move into the activity? So in the absence of any queries, we move into the activity. Someone can answer for this question. Udari, would you mind answering this question?
Yes, madam.
Yeah.
We can do.
Or just highlight the important words in this history.
Okay, ma'am.
Yeah.
They felt very tired and noticed poor work tolerance over the past month.
So, sorry for disturbing. So before you jump into the symptoms, you have to always mention the age and the sex of the patient. That's very important. When you present to somebody, also always say it's a 52-year and he's a male. Okay? So those things, it has to come in your mind first. Okay, you carry on.
And then he was a vegetarian for past 10 years and did not smoke, chew betel or consume alcohol. And examination pale looking, no lymphadenopathy and no hepatosplenomegaly.
Yeah. So what do you think with this history? So what sort of things that comes in your mind? What could be this?
As he looks pale and he has symptoms of fatigue and poor work tolerance, it may be anemia. And also, since he does not have hepatosplenomegaly, it is unlikely to be a hemolytic anemia.
Who said that hemolytic anemia will have hepatosplenomegaly? Have you studied about hemolytic anemia?
Just a guess.
No. Yeah, what you said is correct. It depends on where the breakdown is occurs. So mainly if the breakdown of red cell occurs in the spleen and liver, then you will have hepatosplenomegaly. But there are some of the condition with the hemolysis where it occurs intravascularly. In those conditions, you won't have hepatosplenomegaly. Okay, you carry on. Yeah, in your history, you said it's definitely he should be having some sort of an anemia. Then?
So since he's a vegetarian, it can be a nutritional deficiency, a B12 deficiency,
Okay, so you are going in a correct pathway. So you are thinking that is anemic and something it should be a nutritional since he's having a past 10 years vegetarian. Yes, and then what do you want to do on him now? So he's in front of you and you're a consultant now and he's asking doctor to do something to me. So how are you going to, what you going to say to him or what do you want to do further on him?
So we can do first we have to do a full blood count.
Yes.
And then a blood picture.
Yes, very good.
Then serum B12 levels.
Yeah, before jump into that, what you will ask, the reticulocyte count, always these three should come together. Full blood count, blood picture, reticulocyte count. Okay? Okay. Shall we pass this to someone else, Udari? Just pick somebody from your batchmate. I don't know anybody except Hasita and you. I don't know anybody. Or do you want me to pick? Shall we ask from Maheshi? Maheshi, are you there?
Yes, madam.
Yeah, carry on. So Udari said that she will ask for full blood count, blood picture, and retic count. And what do you look for on those three?
On the full blood count.
Yes.
In the full blood count, I have to see the RBC count, and then the hemoglobin, the MCV, the MC. Yeah, MCV.
Yes.
Then in the that is for the full blood count. Then the blood picture.
Do you think important of looking the other cells as well, in the sense WBC, neutrophils, and platelets?
Yes, madam.
Yeah, very good, Maheshi. So you will look into that. And in the blood picture, what you will look into?
In the blood picture, I have to see the morphological differences. What are the is the if I'm suspecting anemia,
yes,
then there can be morphological differences, like if it is the hypochromic, if it is hypochromic, or if it is megaloblastic, the size of
don't
the.
use the word megaloblasty, you say macrocytes.
Yes, yeah.
Yeah, fine.
The size of the blood cells and the hypochromic or hypochromic or not.
Yes.
That is in the blood picture.
Yes.
Then.
But you will look into red cell morphology. So you correctly said is hypochromic or not, and macrocytic or not. And what in the macrocyte, what you will look for is, suppose if there is a macrocyte, what you will further look into that macrocyte. Shape of the cell, isn't it?
Yes, in the macrocyte, the shape of the cell. And
so what are the shapes of the cells?
There can be oval shaped macrocytes. then there can be round
Very good. Very good.
macrocytes.
So, very good. So you will look for whether there is a round macrocytes or oval macrocytes. Then is this the only macrocytes are you, or only the red cells are you worried about? Are you worried about something else in the blood picture, or you will look into specifically, you will search for it in the blood film?
I can see for the change of the other cell lines.
Very
and
good.
if there's any pancytopenia or not.
Yeah, and hypersegmented, isn't it? Neutrophils are hypersegmented or not? Okay.
Yes.
And yeah, what else? So that's all about the blood picture. You correctly said about the full blood count. Can we pass to somebody else? Hasita, would you like to say something? Hasita is not in, she's gone now. Hasita, are you there?
Yes, madam, I'm here.
Oh, fine. So would you like to add on anything, or what else do you want to ask? If you are satisfied with the full blood count and blood picture, would you able to diagnose at this point, or would you like to ask some more investigations?
About
That's fine, Hasita. If you think something, just tell me. It doesn't matter whether you are telling wrong or not.
you have to ask about urine report.
Before, what else you will ask for it? Like now the patient with, okay, now we are going in a macrocytes, and Maheshi and Udari said that you will look for blood picture changes and full blood count results. For macrocyte, what you will further investigate, or what you will request other investigations?
Vitamin B12 and folate levels.
Very good. And what else? So you are going into the nutritional anemia, but yes, I agree, more likely to be a nutritional anemia on this gentleman, but would you like to ask some more investigation rather than you want to stick to only the nutritional anemia?
About TSH levels
And you can ask for liver cell, liver function, thyroid, isn't it? You have to think about in that way also. Don't try to stick on the one line. So you have to, in the initial preliminary investigation, to try to exclude the other investigation at the same time. We know this gentleman is going to have some sort of a nutritional anemia. That does not mean that this gentleman can't have any other disease, isn't it? So always you have to ask for those investigations. And so I'm going to put some more investigations here. So just can anybody tell whether this full blood count report is compatible with what Udari and Maheshi is talking about? Or do you want me to pick someone from your list? Darshani? Darshani?
Hemoglobin levels are reduced.
Yes.
Then MCV is also high.
Yes. And other two are looks okay.
Yeah.
With IMCH, but you better focus more on the hemoglobin and MCV. But MCH, we tend to see when we study about this microcytic hyperchromic anemia, because that plays important role there. But because in MCH is try to say your chromasia of the red cells, whether it's a hyperchromic or normochromic. But whereas the MCV tells your size of the cells, macrocytic or macrocytic. Okay, so yeah, moving to the WBC.
WBC level is okay, it's normal. Then RBC count is low.
Yes, very good. What do you think about platelet count?
It's in normal level, but margin.
150 to 450. So it belongs to normal range, isn't it?
Yeah.
So it looks like isolated anemia, and that is macrocytic anemia, isn't it? That's how you have to interpret the full blood count. So we know this is anemia, other two cell lines are okay, and your MCV is macrocytic. So conclusion of this full blood count is macrocytic anemia. Okay? And the reticulocytes, what do you think about the reticulocytes count? So reticulocytes, you all have to study and come reticulocytes count. I will be the PBL is bit related to reticulocyte count, so we can teach that in the PBL how you calculate reticulocytes count. What is the importance of reference? We will be touching in your PBL tomorrow. So you all just read around it and come. I'll let you all know at the PBL. Okay, and so this is the blood picture. Can we pass to somebody else? Passing to Deshan.
Yes, madam.
Yeah. So what do you see in the blood picture? Are you happy with Maheshi and Udari's discussion about the blood picture?
Yes, it bit related. So it shows macrocytes.
Yes.
Macrocytes, and also there are hypersegmented neutrophils.
Very good. Okay, because you have to calculate this neutrophil logs, isn't it? So here you can see 1, 2, 3, 4, 5, 6 here. So if it's more than 5 log, then you call as a hypersegmented. So that's correct. So you can see macrocytes and you can see hypersegmented. And okay, so our investigations and our thoughts are going in a correct way, isn't it, Pasendu?
Yes, madam.
Yeah, and can you interpret these results?
TSS levels are normal. Serum bilirubin levels, serum bilirubin is direct level is high, and high. So that suggests of increase extravascular hemolysis, usually at liver.
You can't say here. Here you can't. Direct is 0.8. Then it should be 2. No, 2 is indirect. So here the indirect bilirubin, not the direct.
Okay. Can
you appreciate this? Direct is 0.8. The total is 2.8. So deduction of 0.8 then becomes 2. So 2 is the indirect component.
Okay. Okay, ma'am.
So it's not the direct hyperbilirubinemia. This is the indirect or unconjugated hyperbilirubinemia. Did you get it?
Yes, madam. Yes.
Yeah, fine.
Yes.
Carry on, percent.
LDH levels are high, and
yeah. Can you explain why there's LDH is a bit high and the bilirubin is indirect bilirubin component is high? Would you mind explaining to us?
As there's anemia, so the low red cell count. There will be a is it due to
Madam, can
destruction
I?
of red cells?
Sorry? Yes, somebody is trying to say something. Yes. You can
due to destruction of the red cells, they are like dead dehydrogenase inside the cells, and hemoglobin is released. So when they are high in the serum.
The thing is like there will be a bit of a hemolysis in bone marrow. We call that as a ineffective erythropoiesis because you know there won't be a equal maturation between the nucleus and the cytoplasm. So there is a chance that the red cells get disrupted within the bone marrow. Then we call that the process is an ineffective erythropoiesis. So because of there will be a small extent of hemolysis, then you will have this bilirubin bit higher, indirect bilirubinemia, and the LDH is bit higher. That's how you have to explain the indirect hyperbilirubinemia and the LDH in a megaloblastic anemia. Okay? Yes, carry on. So liver functions looks normal. Anything that you can pick up from here?
B12 levels are reduced, serum B12 levels are reduced.
Very good. Is it Pasindu?
Yes, madam.
Yes, very good. That you have picked up here the vitamin B12 levels is lower than the reference range, isn't it? So then you know there is a vitamin B12 deficiency. By doing these tests that you have excluded the liver cell and the thyroid function disorders, and this you can explain by megaloblastic anemia, then then what's your diagnosis, Pasindu?
So it is macrocytic anemia due to B12 and folic acid deficiency.
Very good. Excellent answer. This is how you have to explain it. And instead of saying, very good, I'm really appreciated that you have answered this question because you can't word it like megaloblastic anemia because megaloblastic anemia can be due to something else. So you say that's the vitamin B12 deficiency and this is more or less looks like it's a nutritional anemia, isn't it? Yeah, so what is your further management? Can pick someone else. Dilhani. Dilhani.
Yes, madam.
Yeah.
Give vitamin B12 supplement and increase the dietary intake of the vitamin B12.
Yes. So that's how you treat nutritional anemia. Would you like to investigate further on him? Would you, as a consultant, would you do it? Would you like to investigate further on him why this gentleman is having vitamin B12 deficiency? Or you will stop at that point?
Further investigation.
Yeah, so history is more suggestive of nutritional anemia, but it's better to ask since he's a 52 years gentleman. I just wanted to include some other, whether it can be, what could be the cause for him to have vitamin B12 deficiency. Though we know that it's a nutritional because of the vegetarian, but still I just wanted to exclude some of the other condition can contribute. Okay?
Okay, madam.
Good, Dilhani. And that's all for the lecture today. And if I think I have covered most of the things in macrocytic anemia, but read your textbook and you can supplement your lecture notes here. And anything you all want to clarify it? Or are you all happy with the lecture what I did? Do you all like to have some activity at the end of the lecture? Rather, would you like that component? Because I think that's more interactive, isn't it? What do you think, Udari and Hasita?
Yes, madam, it's good.
It's useful, isn't it? I think that you just doing a lecture, but if you ask some question, then you know how to write the answer for this question, isn't it? Rather than just doing the lecture, I feel it will be useful. But I'm not sure whether you are thinking that I'm harassing you all at the end of the lecture, asking question or picking up people. Don't think so, but this is, I just wanted to everybody, but everybody should participate in some interactive lesson. Okay, and so there is a PBL tomorrow. It's group 6 I will be doing a PBL, and I will send the link for them to share. So there are somebody from a batch rep, I think they have given to us in that group. So I will be sending the link to you. Okay, thank you so much. Thank you for patiently listening my lecture. Thank you.
Thank you.
Thank you.